All right, I'm gonna get rolling just for the sake of time to keep things moving. Hello, everybody. My name is Natalie. I'll move to the next slide. My name is Natalie. I am an M4 or a fourth year medical student currently at Medical College of Wisconsin. Um, I did my undergrad at the University of Minnesota, majored in, as I have noted here, biology with minors in Spanish and neuroscience. Like I said, I'm at NCW and I'm in my fourth year. So I am actually applying to residency currently. So if there are any applicants who are in the process of going to medical school, I definitely feel you. This has been a real throwback to when I was an undergrad. So it's kind of wild, but it does come full circle. And I'll be applying combined internal medicine and pediatrics in the fall. So that is a combined residency program. I will be dual board certified by the end of it. It's 4 years. Internal med just by itself is 3, pediatrics just by itself is 3, but combined, I get to do it in 4, which is exciting. And then I have been working with Motivate MD for quite a long time now. It feels like this is my 4th cycle. And I do essentially everything with the application cycle. So whether that is editing, advising, interviewing, coaching, the blog posts, and then I'm just getting into doing some of this virtual shadowing. So bear with me if there are some like bumps as we go along here. Okay. And I can't see the chat great. So if there are any questions, like please feel free to just shout them out essentially. Otherwise I'll try to stop periodically to take a look at things, but yeah. All right. So as we kind of move forward here, the session outline for today is we'll of course go through the case, we'll do the physical exam, differential diagnosis, assessment and plan, and then we'll get a little bit of lesson in pathology. I will say for this, it'll be more anatomy than it will be pathology, just because that's like more exciting, I think. However, we'll get a bit of that as well. So before we kind of get into it though, like make sure you've got your like soap link here so that you can fill out your quiz and get all the credit for it. I've got it here and then I've got it somewhere else. So I'll give you guys a sec to grab it. All right, cool. And I'm going to have it again, so don't worry about it. But just like a quick poll to get us started, something fun and lighthearted. We'll see if I can grab it here. All right. And hopefully you all can see it. Let me know if you can't. Wow, okay, we've got a very like wide variety of groups. I'm glad to see that we have such diversity in our ice cream interests. Um, Amazing. My personal favorite is definitely mint chocolate chip. So I'm a little sad that nobody has selected it. Apparently, I'm alone in that preference. Okay, we'll end it for now. All right. If I can get this out of the way, give me 2 seconds. There we go. Okay. All right. So like I said, here's that QR code again, just to make sure that everybody has it. And here's the SOAP note that you guys will all be like filling out essentially as we move through this. Okay. So let's go ahead and get started then. Okay. So I want to start off kind of with what we would classically have should we be like presenting or meeting this patient in the hospital for the first time. So this is essentially what I would call a one-liner. It's how we present any patient who when we're talking to another health professional. And it's meant to sort of give a framework and a context about thinking about this patient in kind of before we even like walk through the door and see what's going on. So our one-liner for this patient is Mrs. M. She's a 45-year-old female with a past medical history of hypertension, polycystic ovarian syndrome, and eczema, who's presenting after 18 hours of right upper quadrant pain. And yeah, so the one-liner is going to be really important as you pursue the rest of your training, because again, it's kind of that framework that we initially meet a patient with. And there are three big components. The first one being like your patient's demographics. And that's useful because when we meet somebody for the first time based on their age or their biological sex, we can sort of immediately start to make frameworks or schemas based on what sorts of pathologies are more common in certain groups versus others. So that's kind of that first component of the one-liner. But then we go into the next component, which is their past medical history. Past medical history can be really extensive for patients who have, like, for example, like very chronic conditions. And so as you move through training, you start to learn like, okay, what things are actually pertinent to be including in this versus not. However, I would say early in your training, it's always better to just err on the side of caution and essentially include everything. But you'll learn kind of as you move through, of course, like certain pathologies are just always going to be more pertinent than others. And so examples of that are things like heart disease. Anytime somebody has heart disease, like heart failure, if they have hypertension, if they have coronary artery disease, those are always going to be pertinent. Or even more chronic conditions, things like diabetes or like chronic kidney disease, anything like that. Those are always going to be pertinent, like I said, just to include in this like brief synopsis when you're initially meeting somebody or when you're presenting to like an attending or another physician. And then the third component of this is, why they're here, like the actual sort of presenting problem, the reason that they have come into the hospital or the clinic today. But again, ultimately, these are the three big components, right? Your patient demographics, the past medical history, as well as then the presenting problem. But your one-liner should always truly just be a one-liner. Like it should be pretty succinct, just meant to give a framework for conceptualizing a patient before you kind of dive into the details of what they're about. Okay. So then a little bit more about our current patient that we've got. So whenever you give a history, you start with your one-liner. So we still have Miss M, who's a 45-year-old female. She's got a past medical history of hypertension, polycystic ovarian syndrome, and eczema, who's presenting after 18 hours of right upper quadrant abdominal pain. She reports that the pain started a few hours after she finished dinner last night. She has had similar pain in the past, however, it usually resolves within an hour or two. She's tried taking some Advil, but just hasn't had great relief. And the patient describes the pain as constant, getting progressively worse, dull, aching, and radiating to her right shoulder. Currently, she rates this pain an 8 out of 10. She's been nauseated and has not been able to tolerate PO or oral intakes since yesterday evening, so she hasn't been able to eat anything. She has felt subjectively feverish with a temperature of 99.8 Fahrenheit at home. This is kind of a brief synopsis of a history. This is pretty succinct and to the point. More so that I didn't belabor you all with extraneous details. But the reason that I kind of formulated this way is because whenever we have a patient who presents with any sort of pain, there are certain mnemonics or acronyms that you can use to help you remember all the things that I should be asking about. And for pain, the one that I was taught was OPQRST. And the acronym stands for these specific things that I want to know about anybody who's coming in with pain is when did it start or what happened when it started, right? Is your onset. The provoke and palliate means, does anything make it better? Does anything make it worse? That Q for quality and is essentially how does a patient describe it, right? Because there are certain words that people will use that are more common for certain pathologies over another, right? So for example, if somebody is presenting with sharp zinging pain, that immediately makes me think nerve pain, versus if the pain is dull or aching, it's okay, now I think maybe more musculoskeletal, so it's a muscle problem, not necessarily a nerve problem. And so how people describe their pain is actually has like some correlation to what the things actually are. Okay, but then moving on to R, which is region and radiation. So it's basically like, well, where is the pain located and does it go anywhere? Especially for abdominal pain and chest pain, that radiation piece is really important, because you'll learn later on, but like visceral pain, so pain of like your internal organs, isn't great at like localizing versus, when you poke the very tip of your finger, you're going to know exactly where the tip of that finger is. You're going to know where that poke was, right? But if you like poked somebody somewhere on the internal organs, they wouldn't be able to localize it in the same way. So where it radiates actually can be very helpful. The S then is your scale and severity. So that's the classic, like, on a scale of 0 to 10, 0 being no pain, 10 being the worst pain you've ever experienced, what do you rate it? That's relevant. Pain is subjective, but it's relevant for like patient pain control, basically. And then T, lastly, just being timed. So like, how long has this been going on? Has it changed at all in that time frame, right? Has it been constant? Has it been waxing and waning? Has it been getting progressively worse? Has it been getting better? There's all sorts of things that go into this, but this is like the bare bones of anybody who is coming in with any sort of pain, whether it's back pain, chest pain, abdominal pain, pain in their arm or leg. This is kind of the acronym that I like to use in order to remember, or mnemonic that I like to use in order to actually remember all the things that you need to remember. And I do think that like it gets easier as you get later into training, but when you're in early training, things like this are super helpful. Okay. So then, but wait, aren't there more things I should know about this person? Of course there are. So histories, whenever you take a patient history, it should be really comprehensive. Things that are missed in diagnosis are very frequently because we didn't actually gain a more comprehensive idea of what's going on with this person. So there are always, always more things we could ask about. And a lot of those things include things like, does this person have any allergies? Specifically, we want to know about drug allergies, right? Like if you're in the hospital, I want to make sure I'm not going to give you anything that's going to make you go into anaphylaxis. The next thing being like current medications. And sometimes people can tell me what their medications are, and they can't tell me what diagnoses they have, but the medications give me an idea of, what sort of disease processes we're dealing with. PMH stands for past medical history. So any other sort of problems that this person has, whether it's related to what they're presenting with or not. Next being surgical history. Surgical history is always relevant, but especially for somebody who's coming in with abdominal pain, I want to know if they've had prior abdominal surgeries, because there are things that can predispose you to various disease processes. Next being family history, always useful because that gives me an idea, or it makes me think like, okay, of course, could this be something that's inherited? Is there a genetic component to this? It's useful for that reason. And then of course, social history. So social history is important in multiple contexts. We ask about things like substance use. So whether somebody drinks alcohol, whether they smoke cigarettes, whether they use like heroin, methamphetamines, marijuana, all the sorts of substances. That is a component of social history, but also a component of social histories like occupation. So, what do they do for work? And there are certain people who do certain jobs and are predisposed to certain problems as a result. So always asking somebody what they do for work is really helpful. And then lastly, I always like to phrase it as like, who do you live with at home? And so asking about like, what is their marital status? Do they potentially have children? Do they have pets? Those sorts of things. For the sake of our patient today, we're going to keep it simple and we're just going to say that none of this is important. But just so everybody, remembers, like it's always important to take a pretty extensive history when you can. Okay, so let's get into what this patient actually looks like. So physical exam wise, the first thing that you should always do when you're meeting a patient is, even before you walk into the room, you should probably look at their vital signs. You can learn a lot about a patient and whether they are, potentially sick, or maybe, doing okay, pretty stable based on their vital signs. So this patient has a temperature of 99.5, which isn't a fever. So fever is 100.4 or 38 degrees Celsius. So until somebody is at 100.4, they are afebrile. Even if they are like warm or feel subjectively warm, they are afebrile. Heart rate wise, this person is at 93 beats per minute. If somebody were to be at 100 or higher, we would consider them to be tachycardic. So that means their heart is beating faster than we want it to. It's an abnormal vital sign. And then blood pressure, this patient is hypertensive. So that means they have a high blood pressure. So their systolic blood pressure is 155. Anything higher than 140 is definitely considered to be, a high blood pressure. Their diastolic is 83, which is okay, but even that's a little bit high. Baseline blood pressure is generally runs around 120 over 80. And then respiratory rate for this patient is 18, which is kind of normal, maybe breathing faster, but not like super, super fast. Okay, so then into the actual exam things. So the first thing, whenever you walk into a room and take a look at somebody, is you want to get an impression of like, is this person really sick? And do I need to call for help? Or are they like stable and I can like go through the rest of my exam or not? Because that is an important thing that you'll learn as you go through training, is your attendings will start to ask you, are they sick or are they not sick? And what they mean is like when you walk in and see the patient, or do they look like they're going to crash? or do we think that we can do a couple things before stuff gets hairy? Okay, so the next section though is, and generally physical exams are broken down by system. So the next one though is HEENT, which is head, eyes, ear, nose, throat. And so this person's pupils are equal, round, and reactive to light. Their extraocular motion is intact. That means that their eyes are moving all the directions they're supposed to. They don't have scleral icterus. Does anybody happen to know what scleral icterus is? Feel free to shout it out or pop it in the chat. And if not, I'll answer it anyways. Okay, we'll keep on moving then for the sake of time. So scleral icterus is when the sclera, so like the white part of your eye, is yellow, basically. It's like the specific term for your eyes being jaundiced, basically. It's called scleral icterus. And then the conjunctiva are normal, so the lining of your eye looks okay. Cardiac wise, this patient had regular rate and rhythm, normal S1, S2, which means that their heart valves are closing the way that we would expect them to by normal S1, S2. That's what that means. No murmurs, rubs, or gallops. Their radial pulses are palpable, and their capillary refill is 2 to 3 seconds, which is okay. Then respiratory wise, listening to somebody's lungs, they don't have any increased work of breathing, which is great. They are clear to auscultation bilaterally, which basically means that there's no weird sounds and there's good breath sounds in all of their lung fields. No wheezing or coarse breath sounds noted either. So then the abdominal exam, which is really what we're probably most interested in this patient with abdominal pain, is this patient has normal active bowel sounds. So everything's moving the way it should be. They don't have any scars. So for sure, they haven't had any abdominal surgeries, more than likely. However, they're tender to palpation. So when I press down, it hurts in their right upper quadrant in their epigastric region. They also have a positive Murphy sign. And I don't think anyone will probably know what this is, but a Murphy sign is basically you have somebody exhale, right? And as they exhale, you press your hands down right below the right side of their rib cage. So as they exhale, you're pressing down right underneath their right-sided rib cage, right? And you keep your hand down as they start to inhale again. And if they stop, right? If they suddenly stop that inhale, that's positive. So again, you're like pressing down in as they're exhaling. And then when they inhale, if they stop inhaling because it hurts, that's a positive Murphy sign. A positive Murphy sign is it's sort of pathognomonic, or it immediately makes us think about a gallbladder problem. Because if you think about it, as somebody inhales, their thoracic cavity expands and your diaphragm pushes down, right? And so as your diaphragm pushes down, it pushes your liver and your gallbladder up. Basically, it's kind of hard to describe. So then your liver and your gallbladder become a lot closer to, like, their skin. And if that gallbladder is really inflamed, then that's going to hurt when you press on it. Okay. But otherwise, abdomen is non-distended and they don't have any hepatosplenomegaly, which means their liver and spleen are like totally normal size. Great. So then musculoskeletal and skin, they don't have any gross deformities. Things are warm, dry, no rashes. They're not jaundice, which is good. And then for neuro and psych exam, there are no focal neural deficits. So everything is looking okay. Things are moving all right. Normal thought behavior, so on and so forth. Okay. Does anybody have any questions before we move into differential diagnosis things?
I have one.
Yeah, absolutely. Go
And
for it.
I wanted to know what was the jaundice, the last term that was highlighted.
Yeah. Let me see if I can go back. Yeah. So jaundice is basically when somebody's skin looks really yellow. It's this kind of like, yeah, it's hard to be like, it when you see it, but essentially that's it. Is like jaundice is when people's skin looks really yellow. And we can talk a little bit about why, unless somebody knows how jaundice happens.
Um, doesn't it has a relationship with the liver and liver failure?
Yeah, I don't know. You don't have to jump right to liver failure, but definitely bilirubin. So when people are jaundice, it is because they have high bilirubin. And so that can happen for multiple reasons. But bilirubin is a pigment, which is why your skin and your eyes can change color because it's a pigment. And it actually comes from red blood cell breakdown. So when your red blood cells lyse and break down, the bilirubin is a component of that. So actually, when you get a bruise, and your bruise changes from this like gross purple to like green to yellow color, that is the result of that bilirubin being um, essentially broken down as that bruise goes through that healing process. But that is where the color comes from, basically. And so there's a couple things that can cause an elevated bilirubin, right? It can either be, well, we can go into it, but it can either be a direct bilirubin, elevated bilirubin, or it can be an indirect elevated bilirubin. And so basically the two big things is if it's a direct bilirubin, then it is conjugated, which means it's been through the liver, which means that there's an obstruction somewhere in the biliary tree. If it is if it is indirect, that means it is unconjugated, which means it hasn't been through the liver, which means it's probably due to like your red blood cells being lysed for one thing or another. That was probably more than you wanted to know, but hopefully I did answer your question specifically about jaundice. Yeah.
Yes, thank you.
Okay, great. Cool. We'll keep going then with differential diagnosis things. So there are, again, lots of ways, lots of kind of crutches or things that we use to think about pathology when we're initially meeting somebody with a different, for the first time and they've got a specific problem. For abdominal pain, most people like to think about it in the context of like the quadrant system, right? So our patient has right upper quadrant pain. And so in the quadrant system, it's based on the idea that all of your internal organs are, for the most part, located in the places that they always are. Like some people, they move around into weird places, but for the most part, everybody's liver is going to be in their right upper quadrant, everybody's gallbladder, all of that, right? And so it operates under this assumption that pain in your right upper quadrant is probably going to be due to one of the organs that's currently there. So those are things, like I said, like your liver, your gallbladder, your biliary tree, so your bile duct system, a little bit of your colon, so like your hepatic flexure, and then like your transverse colon. So your colon is your large intestine. Um, and then a little bit of your small intestine too can kind of hang out around here. Um, So those are like the things that we're gonna probably initially think about, right? If this person were to have left upper quadrant pain, I would instead think about their spleen. I would probably think a little bit more about their stomach or maybe their pancreas, right? If they had left lower quadrant pain, I would think about probably their rectum and parts of their large intestine. So I would think about like diverticulitis is the classic one. Or if somebody has right lower quadrant pain, most people know the right lower quadrant pain, we think about your appendix, because that is generally the main organ that kind of lives there, right? But one thing I would say to consider is that if you have a patient who, is like female sex, you also have to think about things like reproductive organs, right? So even if I have a patient come in who is a female sex, childbearing years, I have to think about like, could they have some sort of reproductive tract problem? Could they have an ovarian torsion? Could they have an ectopic pregnancy? Could they have like, what am I also thinking of? Like pelvic inflammatory disease. Like there are multiple other, or in a burst cyst, like there are multiple other things that I have to consider based on the concept of like, oh, this patient is a, has female sex versus if they do not. So there's like all sorts of things to be considering. But again, our patient generally has right upper quadrant pain. So that's what we're going to go with. So the first things that we think about, hopefully everybody can see this. The first things that we can think about as far as like the most likely problem based on the fact that this patient has, like I said, that right upper quadrant pain, the fact that their Murphy sign was positive on exam, the fact that this has been like a constant pain for the past like 18 hours and that it started after eating is all kind of pointing me in that direction of like, oh, this is a gallbladder problem. Um, does anybody know what your gallbladder does? It's okay.
I think it's when where we store the veal.
Exactly. Yeah, exactly. So Maya, Colleen, Haley, everybody got it right. So it stores your bile. I'm glad you said it stores your bile because the trap people fall into is like, oh, it makes the bile. No, your liver makes the bile. So essentially, your gallbladder is responsible. You're like your liver is just making too much bile for you to actually need to digest your food, and so it all gets stored in your gallbladder, right? Um, when you eat, then there's like hormones that go along with eating, right? And so when that one of those hormones called cholecystokinin gets into your bloodstream, it causes your gallbladder to contract, right? So it contracts down to push out the bile that it has stored into that biliary tree to then go down into your intestines and help you digest your food, right? Um, so that's helpful for us knowing like, well, what kind of gallbladder problem are we talking about? Because there's a lot of different things that could be wrong, right? And so one of them is biliary colic, and so which is essentially the same thing as cholelithiasis. Does anybody know what cholelithiasis is? It's a big fancy term for something pretty simple. I'll say it anyway. So cholelithiasis is like as a gallstone essentially. So anything that has the thing I'm gonna forget it. It's not a prefix. It's not. Maybe it's a suffix. I can't remember. The end of the word, if it says lithiasis, it's a stone. So basically, gallbladder stones are made up of like cholesterol, cholesterol and bile and all these other gross things. When it just hangs out in your gallbladder, it can like condense and get contracted and then it creates these stones, right? So biliary colic is when your gallstones, when that gallbladder contracts as you're eating, it can push those gallstones into the cystic duct, which is what connects your gallbladder to like the rest of your biliary tree. And so when it gets stuck, that hurts. Like that really hurts when that little stone gets stuck in this really teeny tiny little lumen. Okay. But if it goes away when your gallbladder relaxes, then it's just colicky, right? It's not there all the time. So that's why it's called biliary colic, right? Alternatively, you can have acute cholecystitis, which is when that stone gets lodged in your cystic duct. And I'm going to show you a diagram of the cystic ducts later on. So that's when it gets stuck, right? And can't get out. And that's a little bit different from cholangitis. So cholangitis can be caused by gallstones, but not always. And so basically that's just inflammation of your biliary tree, which is what carries bile down, like I said, from your liver, your gallbladder into your intestines. And so that's just a fancy name for that to be inflamed, right? And then lastly on this list, you can have acute choledocholithiasis. And that's like a fancier name, but we know it has something to do with stones, right? Because there's stones at the end of it. And so basically that is when your that gallstone isn't just stuck in the cystic duct, it gets stuck a little bit further down your biliary tree. And so there's backup that essentially also includes other organs that contribute to your biliary tree. So there's basically three things that do that. That's your gallbladder, your liver, and your pancreas. So, okay, cool. We'll move on. I won't keep boring you with this. But still, like those are the most likely things, again, just given this patient's presentation. But we always have to consider the other things that could potentially be going on as well, which are processes like the liver, right? Because the liver is still hanging out in your right upper quadrant. Appendicitis is always an option. Like you would be surprised, like especially if you have a patient come in who's pregnant. When like somebody's pregnant, that their uterus grows, right? And then it takes up way more space in their abdomen than it's supposed to, and all your internal organs get all pushed around. But appendicitis, or if like the appendix isn't quite at the front, sometimes it can be like tucked in the back of the colon here, and sometimes then it can have like more of an upper quadrant presentation as well. So it's just always on the differential. Less likely, but potentially. And then next is like a small bowel obstruction. So again, you've got intestines here. If something gets stuck there, it can hurt, right? And then less likely, but we have to always consider, is an ischemic process. So ischemia happens when an organ isn't getting perfused adequately. So there's not enough blood flow getting to the organ. It's ischemic. A neoplasm, which is cancer. Um, Less unlikely to cause an acute presentation, but it's always possible. An autoimmune problem. So there are specific autoimmune diseases that attack your biliary tree, right? An infectious process, and then trauma. And like usually we know about trauma. Usually somebody comes in and they're like, oh my God, I just got run over by a car. We know about things like trauma, but occasionally we don't. Like if we have a patient come in who is unconscious, right, because of this trauma, I have no idea what hurts and what doesn't hurt because this patient is not conscious and I can't talk to them about it. Okay, we'll keep going though. All right. So then we'll go into like assessment and plan things. But essentially, your assessment is a way of summarizing the most pertinent parts of, you know, what your patient has presented with, and including like, okay, also what you think it potentially is. So like for this patient, my assessment would be, you always start with your one-liner. So my assessment would be Miss M is a 45-year-old female. She's got past medical history of hypertension, polycystic ovarian syndrome, and eczema, who presents after 18 hours of right upper quadrant pain. She is afebrile, but hypertensive. On exam with notable tenderness to the right upper quadrant and positive Murphy sign. So differential diagnosis includes acute cholecystitis versus choledocholithiasis versus another intra-abdominal pathology. And so this is like, it's again like a framework just to think about something in, right? But within your assessment should always be included whether somebody is what we call hemodynamically stable. So if they are, like if their blood pressure is super low, bad, right? That should always be included in your assessment. If their heart rate is super high, bad. We always have to include that in the assessment. Okay. So then I thought I would pose it to the group, but does anybody have any idea what sorts of tests they would like to run on this person? And you don't have to know like specifically, but just like in general, things you might think about. Okay. Maybe an endoscopy. Okay, great thought. Trying to look inside, see what's going on. Abdominal ultrasound, also a great thought. So maybe some imaging studies, it's sounding like you guys are interested in getting. Anything else? Blood work. Yes, we're going to give blood work on this person too, definitely. Okay, we've covered the big categories though, which are like imaging studies, because I want to know like what's going on in their belly, right? And then blood work, because why not? And I'll tell you why the blood work is important a little bit later on, but that's a great start. So, diagnosis and evaluation. As far as imaging studies go, we got to get that right upper quadrant ultrasound. An endoscopy is a great thought. However, endoscopies look basically inside any part of your GI tract, right? So it can see inside your stomach, it can see inside your small intestine. It can't quite see inside your gallbladder, though. So it's a great thought, but just not quite what we would use for it. The right upper quadrant ultrasound, though, very, very useful when we're evaluating somebody for gallbladder etiology. Um, Basically, it's going to be the best thing to use. What's going on here? So, and the reason why is because it's non-invasive, which means you don't have to like cut anybody open to do it, right? It's pretty inexpensive. So, like compared to a CT scan or an MRI, ultrasound is like pennies. And then it has really high sensitivity and really high specificity. And I'm not sure if you guys will oh my goodness, what is going on here? I'm not sure if you guys will necessarily need to know this for the MCAT, but sensitivity and specificity are really important things that we talk about when we are evaluating whether a test is like useful or not. And so like high sensitivity is how likely the test is to correctly identify it if it's there, right? So high sensitivity means you don't really have false negatives, which means you're very unlikely to miss the disease, right? And then specificity means that if you identify it, how likely is it to like be that thing for sure? So high specificity means you have a negative, like having, it means a negative result is like definitely negative, basically. So right upper quadrant ultrasound is the first thing we'll do. Blood work wise, we're going to get a couple things. So we're probably going to get a CBC, or a complete blood count. That is going to include various things, looking at your blood cell lines. So those are things like your red blood cells, your white blood cells, your platelets, so on and so forth. Specifically, we're going to look for leukocytosis, which is a very fancy word for a high white blood cell count, which is very common when people have infections, right? And then next, for blood work wise, we're going to get a CMP, so a complete metabolic panel. A complete metabolic panel is different from a basic metabolic panel, which is a BMP, because it also includes your liver function tests. So a comprehensive metabolic panel is going to include the electrolytes. So the main ones in your body are going to be like sodium, potassium, chloride, so on and so forth. And then your LFTs, your liver function tests, which the next slide I will show you guys what it is. Some also include calcium. It just depends on the test, essentially. Okay. Alrighty. So these are our results. And so that right upper quadrant ultrasound, they go down to the lab, the tech does it, right? The radiologist reads the report or reads the ultrasound images, and this is what they tell you. It says there are stones present in the gallbladder lumen, right? So this is the lumen, right? It's basically the part of the organ that's hollow, okay? And these are the stones. And you know that they are the stones because they have this shadowing, is what it's called. So if you remember, ultrasound is basically a bunch of sound waves, right? And so based on like how it bounces back and how deeply it penetrates, that creates this image, right? But the stones are so dense, the sound waves can't bounce any deeper through them. And so it creates this shadowing, right? And then they say also present is gallbladder wall thickening. So that's this here, edema and distension, most consistent with acute cholecystitis. Right? Oh, goodness, that's not what I want to do here. Okay. Also, though, we got our blood work back because this is the fastest lab known to man. It took no time at all, which is fantastic. And so in this blood work, these are all of our numbers. I'll explain what these mean. So this fancy like X and this sort of weird thing down here, those are called fishbone diagrams. And they are like this tool that we use essentially so that I don't have to write down sodium 136, potassium 4.3. I can just look at where the sodium level is going to be and where the potassium level is going to be, and I can know that's what it is, basically. So, but for this complete blood count, there's multiple components, but these are the main ones, right? So this 14 that's red, it's because it's high, is your white blood cell count. So most people's white blood cell counts will be under 11. So 14 is high, which means you've got a higher white blood cell count, which makes us worried about infection, right? This 13 right here is representative of your hemoglobin. Okay, hemoglobin is what carries oxygen throughout your bloodstream and delivers it to your tissues within your red blood cells. This is your hematocrit, which is basically like the percentage of your blood volume that you consider to be red blood cells. Kind of weird, but that's what it is. And then this 172 down here is your platelets. So platelets are the most important thing to create blood clots. And this person's platelets look just fine. So if I was I knew that if I poked them, there's a good chance that they would clot just fine. Okay, then going on to like this comprehensive metabolic panel. The first thing is the BMP, which is this fishbone diagram here. I can get this out of the way. And for our patient, their sodium right here is 136, which is normal. Their potassium is 4.3. Their chloride is 101, also normal. Their bicarb, so bicarb is, what is it? It's like HCO3 negative, I think. It's a major ion in your body, which is why it's a component of your basic metabolic panel. So it's 23. Their BUN or blood urea nitrogen is 14, which is also normal. This is a marker of kidney function, right? So is this number down here, which is your creatinine. So a creatinine less than 1 is normal. It's again a marker of kidney function. And then their glucose is 108. Cool. So then their LFTs, their albumin is 4. Their alk phos is 253, which is high. Their AST, ALT, and T-Billy are normal. So all of these, kind of except this alk phos thing, are all related to their liver function. So their liver is looking good, except for maybe this thing right here, because it's not. This is related to your biliary tree. So this level is elevated when people have problems in like their cystic duct, right? So overall, when we look at this blood work, liver's looking okay. Gallbladder, maybe not so much. Kidneys are looking good, great. But maybe there's a little bit of infection somewhere because they've got a white blood cell count. Okay, does anybody have any questions before we keep rolling here? All right, okay, we'll keep moving on. So then here's that anatomy that I was talking about a little bit earlier. So sometimes I think this is easier to like conceptualize when you see this, which is called a cholangiogram, right? This is basically what you do is you inject dye into that biliary tree, right? And then you take an X-ray. And I've actually seen this done in the OR, which is kind of wild. So your gallbladder here, right, connects to the biliary tree through your cystic duct, okay? This is where our stone is stuck, right here. And so if we were going to do this test in the OR, we wouldn't see this gallbladder because the stone would prevent all the dye from moving forward, right? But stones can also get stuck like further down, like here in the common bile duct. And when that happens, none of the dye will get up to the liver, which is up here, right? Because you won't be able to get up to the common hepatic duct. There'll be a blockage. So a cholangiogram is really useful to see like where the stone is, essentially, because we always want to make sure that we actually take it out when we need to. And so basically this is, like I said, this is like what that looks like. But also you can see like this is the person's spine back here, essentially. So yes, I hope that's helpful to like visualize things. Does anybody have any questions about that? All right, cool. We'll keep going. Alrighty, so this is where we get into some of the more like pathology things, or not even pathology, because the anatomy is really what I think is most useful here when we're talking about this. But like, what do you do? So essentially, all of our lab tests confirmed this person has what we would call acute cholecystitis. So they have got a stone lodged right here, right in this cystic duct, okay? And that is supported by the fact that They have a white blood cell count, so it's higher. So there's maybe a little bit of an infection. Their alk phos, which is that measurement of kind of inflammation for this, was elevated, but their liver values looked good. So I'm not worried about a stone being stuck in their common bile duct, because if it was stuck in their common bile duct, then we would see like increased bilirubin. We would have seen this person potentially be jaundice and things like that, which this person didn't have. So I'm feeling pretty confident that the stone is stuck in the cystic duct. Okay, so then what do? We take it out, essentially. Very luckily, you do not need your gallbladder to live. And it is one of the most commonly performed surgeries in the United States. Like, I think, if not the most commonly performed surgery, it is it's done very, very regularly by almost all general surgeons. Some people who have their gallbladder taken out will also get antibiotics. Usually they'll just get a dose before they take it out. And the antibiotics they use are called ceftriaxone and Flagyl or metronidazole. And the reason that they use those two antibiotics is because you want to cover for gram-negative bacteria as well as anaerobes. And so those are the reason that we pick those two. Or we use Zosyn, which is piperacillin tazobactam, for the same ideas. You want to cover a specific type of bacteria that could potentially be in somebody's intestines and therefore move all the way up into their gallbladder. Okay. But ultimately, this is a pretty quick and pretty easy surgery, actually. It takes like usually not that much time. Frequently, we'll do it what's called laparoscopically now. So for those who don't know, a laparoscopic surgery is instead of having, one big incision that you stick your hand in and like pull everything out, essentially laparoscopy, you have multiple small incisions. So usually there'll be an incision in somebody's belly button, and then there'll be one a little bit higher, and then one maybe a little bit more to the right. And through those small incisions, you basically they're called trocars or trocanters. I can't remember. But you insert these like big long poles that have like graspers and like Bernie things at the end. And essentially you kind of pretend like you're a robot, basically. You like go around, move things out of the way and get stuff going. And it's a much cleaner way to do surgery. And people have much better recovery time because they don't have this massive incision on their side anymore. They just have a couple small ones that need to be sutured up, essentially, and they can go home usually the next day, sometimes the day of, if they're doing well enough. Okay, so then quickly, just a little bit of pathology is this question of like, how do people actually get gallstones? So like many things in medicine, it's a mix that causes it. The main component of a gallstone is cholesterol. So if you eat a really high cholesterol diet, it can definitely contribute. But there are also genetic components to how you metabolize or transport cholesterol. And then like people who have what's called bile stasis. So like if your gallbladder isn't contracting frequently and the bile just sits there, that can cause stones to develop. So if somebody has really prolonged fasting and they're not eating, so their gallbladder is not contracting, that happens. Or if they're getting total peripheral nutrition, all those things. And the risk factors for developing this include like obesity, hyperlipidemia, diabetes, pregnancy, female sex, increasing age, all these things. Okay. These are essentially my sources. I'm sorry, I do not have very fancily formatted ones, but largely, a lot of this was largely from my curriculum, like from my experience on my surgical rotation, what I had learned about it. And then I just verified things essentially to make sure I wasn't telling you guys the wrong stuff. Okay. Does anybody have any questions then, kind of before we close things out? This one too. And does everybody have the link to the SOAP format? SOAP note. Oh, that's a great question. Do patients need any medicine or extra aid if they don't have their gallbladder? So no. Interestingly, they don't for the most part. So essentially, as long as basically it's like trial and error once somebody gets their gallbladder taken out. There's no like medical thing for us to say like, no, you definitely can't have XYZ food. No. Basically, they just have to find like, is there food that they tolerate versus they don't tolerate? So there's a good chance that like after you have your gallbladder taken out, some of those fattier foods, like fried foods, things with higher cholesterol, all sorts of stuff, that maybe now that causes them to like have diarrhea or like have just intestinal upset. Like it doesn't feel good to eat those foods anymore because arguably they don't really have the bile to help them digest it. And so that can cause them to have like diarrhea or that discomfort. So there's no like thing for us. There's no reason, like we don't have to tell people like, no, you have to avoid this food. Um, but it's some people will end up having like intolerances to various foods, but there's no specific medicine or extra aid that's needed. That's a great question. Anything else?